Thank you very much. Some disclosures. So this talk is like a half full, not full enough talk because it's a challenge to answer the questions. So what I want to do is review global hepatitis C epidemiology, highlight gaps with traditional surveillance, introduce molecular epidemiology, and suggest that an arranged marriage between traditional surveillance and molecular epidemiology might be a solution to better assess the global hepatitis C disease burden. So in this figure, the population burden of hep C at any point in time is really the number of new infections, which are incident, and with an adjustment for spontaneous clearance, because you have to do the RNA. The number cured, which is a drop in the bucket, because up to now the uptake has been poor and the effectiveness has been poor. And then, of course, the mortality, either because of the acquisition risks, injection drug use, etc., or the viral sequelae, and of course the comorbid conditions, and of course aging. In the developed world, the high-risk population, as we've heard by many, is current transmitters are predominantly people who inject drugs. In terms of moderate transmission, they are the bridging transmitters, MSM, sex trade workers, who can bridge transmission between people who inject drugs and the general population. And in general, you have these low-risk baby boomers because they've stopped their risk activities, and also immigrants to the developing countries. In contrast, in the developing world, you have a series of unsafe needle practices and unsafe medical practices, plus or minus unscreened blood products, which creates a high-risk transmission group to the general population. You've all seen this slide by Mohad Hanafia, and suggesting that the burden from an antibody seroprevalence perspective is 185 million. And if we assume that 25% will clear spontaneously, and that's pretty consistent, we have about 138 million viremic cases. As we heard in the symposium this morning, one of the challenges is coming up with a mortality adjustment. And Gower, which is Homi Razvi's recent publication, reported these adjustments and tried to extrapolate the estimates. And in that paper, they reported that the global antibody prevalence is actually about 1.6%, of which 104 million, between 87 to 124 million, were adults, greater than 15 years old. So in that population, it's about 2%. And then adjusting for RNA, 80 million people, between 64 to 103 million people were RNA positive, or about 1.1% were viremic. Most were adults, and this was commented on also at the symposium. One of the challenges, of course, is those estimates are unclear. The estimates for all of India were similar to the estimates for Pakistan, and just China alone could change this estimate. So the reality is no one has a good estimate, and the numbers are fluctuating quite widely. Another point reviewed by Dor et al., Greg's group, basically puts the population in the world into the groups that are really being successful at testing people. Greg, do you believe that it's truly that high in Australia? And we Canadians are supposed to be pretty good, and Sweden's pretty good. And then you have the countries that are reasonably good at testing and more proficient at treating, but up until now the therapeutics weren't very effective. And for the bulk of the world, they neither treat well or diagnose well. So that's a huge problem. This figure highlights the countries responsible for 80% of the total viremic infections globally, and most of them, of course, are not in developing countries. So if we were going to take a population approach and you wanted to optimize population level outcomes, one, of course, would want to decrease transmission through the use of single-use syringes and needles. and certainly trying to improve this infection control framework because unsafe needle practices are quite prevalent. And then we've heard about treatment as prevention, which would require harm reduction, or we heard this, just the speaker before, about the potential of using vaccines in people perhaps who got treated for disease in their people who inject drugs. Then you have this large baby boomer or age cohorts, which differ significantly by the different countries. And so if you really wanted to come to grips with this, you'd want to better understand the local transmission dynamics. So what is driving the incidence in your country? And you also want better measures of prevalence in terms of those that are undiagnosed, untreated, treatment failures. And this requires a surveillance capacity that is sadly lacking in most countries in the world. And you'd also want to create a triage process where you could prioritize treatment to those most in need, and we heard about this during this conference. And the challenge in terms of prioritization is trying to prioritize both in terms of an affordability as well as a capacity perspective. And ideally to avert existing health costs, which are largely liver-related, and that's probably seen most in the developing world. And then follow up potentially with broader treatment to achieve elimination. So I'm suggesting that what needs to happen is a blend of classical epidemiology with molecular epidemiology, and that's what I'm going to explain. So as you all know, the virus hepatitis C mutates fairly rapidly, and there's a time frame for those mutations to occur. So the molecular epidemiology can characterize the transmission history of an epidemic. The genetic diversity of hepatitis C and the transmissions unfold at the same time. And people with similar sequences represent transmission clusters. And the factors are, of course, the virus has quasi-species, and this is a function of replication, so those viral variants. Those are affected by the host immune response. They are affected by the fact that the virus has to remain fit in order to replicate. It's affected by different hosts that are infected. It's affected by the genomic region that you're looking at and the technology that you use, Sanger sequencing versus next-generation sequencing. So in this paper published by Gytis Maiorkinis sorry for wrecking that name, in 2013, what they did was to integrate phylogenetics and epidemiology to estimate transmission diversity in viral epidemics. And in blue, you have essentially the genetic data using Bayesian skyline plots versus in orange, sorry about the colors, estimating the surveillance data using back calculation. And whether it's a subtype 1A, subtype 1B, 3A, or 4A. And essentially, you see that the plots are almost identical. So the information you get by surveillance, traditional surveillance, and back calculation is almost identical to what you get by molecular means. And these plots were truncated after 1990 to characterize the transmission epidemic prior to the discovery of the actual virus. So our laboratory does most of the testing for British Columbia. We have tested 1.38 million people in British Columbia, just over a quarter of the population of about 4.6 million. We've identified 75,937 as of people who are antibody positive as of September 21st of this year, and that includes 9,106 seroconverters since 1992. And every night we've developed an electronic way of identifying these seroconverters on a nightly basis. So when you're working in a diagnostic laboratory, typically what you'll find is a patient who's a first-time positive, and those people have no known infection duration, an unknown infection duration. We also, because of this capacity to detect seroconverters, have past seroconverters where we know that their infection duration was greater than a year. And we also have recent seroconverters, and we specifically looked at those in 2011. And we Sanger sequenced those.
We basically extracted 1,540 samples, detected RNA using an in-house assay, and then were able to sequence 640 of them in 3 regions. One was the NS5B, and we had 593 of those. In the core hypervariable, 415 of those, and hypervariable, 466. And here you have the overlapping regions that we were able to sequence. So what we know when you do phylogenies is you can actually look at the divergence time between different samples, and you have their sampling time. And you also can measure what's called a patristic distance, which is the distance between these 2 tips. And if the samples are distantly related, the distance is far. If they're closely related, the distance is close. And if they're clustered, you can identify those clusters. And so what we did was, because we had the same patient who was tested multiple times, and we had patients from the general population, we set a series of patristic cutoffs where these were the same patients in the different regions tested over the time period, and we could see what that variability looked like. And then if we detected a different patient in these 2 cutoff ranges, we would say that these 2 were transmission events, and we created these. And I'm just going to show you the data for the NS5B region. So these are NS5B clusters. NS5B region mutates slowly, so it's more of a longer time frame. And we can show in the dark area a common cluster, and those that are closely related, those that are more closely related. And this is for genotype 2B, and these are for genotype 3A. And this is using one of the cutoffs, and this is using a slightly higher cutoff to account for some of the variation you'd find in different hosts. What we were able to show was that 11%, or 63, and 92 individuals were identified as clustering in this region. We had no clusters between the BC data and the reference sequences, and essentially baby boomers tended not to cluster because they were infected in the distant past. And we also had 27 individuals and 13 clusters that were identified in all 3 of the genomic regions, so we still need work to figure out which is the optimum genomic region to work with. But more importantly, we found 29 individuals who were identified in clusters in first-time positives. So this is an opportunity to actually identify at the time of diagnosis that they were actually linked to an incident infection. And you can time those infections as well. So those in clusters had an increased likelihood of having had an estimated duration of infection of less than a year, with an odds ratio of 3.19 compared to a first-time positive. They were more likely to be genotype 1A, which is predominant in BC, with an adjusted odds ratio of 4.86. and 3A with an adjusted odds ratio of 2.99. And they were more likely to be less than 40 years old compared to those greater than 40 years old, very consistent with the data for baby boomers not engaging in activities, with an adjusted odds ratio of 1.95. We also tried to differentiate acute from chronic hep C by taking the same NS5B region and deep sequencing it, and essentially identifying those amplicons and looking for the diversity in the sample that's deep sequenced. And this is illustrative of the different percentages of certain subvariants, essentially. And we were able to show that looking at hep C NS5B diversity, we were able to differentiate acute from chronic infection in a very well-defined data set where we had 39 individuals who we had good timing of their infections. So the area under the curve was 0.96. And when we included a larger data set, which is the total data set, we still had an area under the curve of 0.86, which is pretty good for epidemiological purposes to define both incident versus prevalent infections. So in conclusions, we believe that systematic application of molecular epidemiology and integrating that with traditional surveillance could profoundly improve the accuracy of global hep C disease estimates. And the challenge for the developing world is this the right investment for the developing world, because their needs are pretty mammoth. And then the other important point is that from the baseline diagnostic sample, you have now an ability to provide information on infection timing. You have an ability to assess the number of individuals who are involved in transmission clusters, if you do it systematically, determine whether those clusters are growing or stable. And then if you use next-generation-based diversity measures, you have an opportunity to improve your ability to discriminate incident and prevalence estimates. From a population-level tool perspective, you then have the opportunity to identify your incident infections and target your prevention resources, either at reducing iatrogenic transmission or also looking at how effective your treatment is prevention programs, because you have an ability to track what's going on. From your prevalent infection perspective, you could identify the people who are more likely to be infected in the past, and those are the people more likely to be part of the aging cohorts or baby boomers, and those could be shunted for engagement into care. And then ideally, you could also do serum fibrosis marker testing, so you could provide a liver disease triage to help identify those needing more urgent treatment. And this would be particularly helpful in the developing world, but it could work in our world as well. Thank you very much.